Psychosocial assessment. The development of preeclampsia places added stress on the childbearing family. If the condition is not severe and the gestation period is early, the woman may be instructed to reduce her activity at home. She may be hospitalized, complicating care for the other children. This creates anxiety about the condition of the fetus and that of the mother. Many families do not understand the seriousness of the disease. The possibility that a preterm birth may be necessary to reduce harm to mother and infant adds to the family's concern about the outcome. Explore how the family will function while the expectant mother is hospitalized. Determine how the woman is adapting to the sick role and the need of being dependent on others instead of functioning in her primary role. Ask how much support is available and who is willing to participate. Determine whether referrals to manage loss of income are needed. Finally, determine the priority concerns of the family. Identification of patient problems. Analysis of the data collected can lead to both nursing diagnoses and collaborative problems for potential complications. Both physician-prescribed and nurse-prescribed interventions are used to minimize the complications. Potential complications for the woman with preeclampsia are listed in Table 10.2. Planning expected outcomes. Patient-centered nursing goals are inappropriate for the potential complications of eclamptic seizures and magnesium toxicity because the nurse cannot independently manage these conditions. The nurse should confer with physicians and use established protocols for treatment. Planning should reflect the nurse's responsibilities to do the following. Perform actions that minimize the risk for seizures and prevent injury if seizures do occur. Monitor for signs of impending seizures. Consult with a physician if signs of impending seizures are observed. Support the family and the woman with eclampsia. Monitor for signs of MAG toxicity. Consult with a physician if signs of MAG toxicity are observed. Perform actions that reduce the possibility of MAG toxicity. Interventions. Interventions for seizures. Monitor for signs of impending seizures. Assess for changes in the following. Hyperreflexia, possibly accompanied by clonus. Increased signs of cerebral irritability, headache, visual disturbances. Epigastric or right upper quadrant pain, nausea or vomiting, although none of these signs is a predictor of imminent seizure. Nurses should be alert for subtle changes and be prepared for seizure in all women with preeclampsia. Initiate preventative measures. In the presence of cerebral irritability, generalized seizures may be precipitated by excessive visual or auditory stimuli. Nurses should reduce external stimuli by doing the following. Keep the door to the room closed. Heightened surveillance of patient status is needed regardless of the specific room location that is available. Keep lights low and noise to a minimum. This may include blocking incoming telephone calls, instructing visitors to silence cell phones and electronic devices, and turning the noise of the electric monitors, fetal monitor, pulse oximeter, IV pump, as low as possible. Group nursing assessments and care to allow the woman periods of undisturbed quiet. Move carefully and calmly around the room, and avoid bumping into the bed or startling the woman. Collaborate with the woman and her family to restrict visitors. Prevent seizure-related injury. Hard side rails should be padded and the bed kept in the lowest position with the wheels locked to prevent trauma during seizure. Oxygen and suction equipment should be assembled and ready to use to suction secretions and to provide oxygen if it is not already being administered. Check equipment and connections at the beginning of each shift because sufficient time for setup will not exist if seizures occur. Following equipment should be readily available: an ambu bag with mask, reflex hammer, pulse oximeter, stethoscope and syringes and needles. Medications that should be readily available include magnesium sulfate and calcium gluconate. Protect the woman and the fetus during a seizure. Nurses should protect the woman and the fetus during seizure. The nurse's primary responsibilities are the following. Remain with the woman and press the emergency bell for assistance. If she is not on her side already, attempt to turn the woman onto her side when the tonic phase begins. A sideline position permits greater circulation through the placenta and may prevent aspiration. Note the time and sequence of the seizure. Eclampsia is marked by a tonic-clonic seizure that may be preceded by facial twitching that lasts for a few seconds. A tonic contraction of the entire body is followed by the clonic phase, which may last about 1 minute. Maintain a patent airway after the seizure and suction the woman's mouth and nose to prevent aspiration. Administer oxygen by non-rebreather face mask at 10 liters per minute to increase oxygenation of the placenta and all maternal body organs. Notify the physician that a seizure has occurred. This is an obstetric emergency that is associated with cerebral hemorrhage, placental abruption, severe fetal hypoxia, and death. Administer medications and prepare for additional medical interventions as directed by the physician. These interventions are also relevant if the woman has a generalized seizure disorder that is unrelated to hypertension. Provide information and support to the family. Explain to the family what has happened without minimizing the seriousness of the situation. A generalized seizure is frightening for anyone who witnesses it. Explain that the woman will be unconscious and then may be drowsy for some time afterward. Acknowledge that the seizure indicates worsening of the condition and that it will be necessary for the physician to determine future management, which may include delivery of the infant as soon as possible. Interventions for magnesium toxicity. Monitor for signs of MAG toxicity. MAG excess depresses the entire CNS, including the brainstem, which controls respirations and cardiac function, and the cerebrum, which controls memory, mental processes, and speech. Carbon dioxide accumulates if the respiratory rate is reduced, leading to respiratory acidosis and further CNS depression, which could culminate in respiratory arrest. Signs of magnesium toxicity include the following: respiratory depression with a rate of fewer than 12 breaths per minute, chest pain, decreasing maternal pulse oximeter values, less than 95% during pregnancy, less than 92% during postpartum phase, absence of DTRs, blurred vision, altered sensorium, confused, lethargic, slurred speech, drowsy, disoriented, oliguria, hypotension, serum magnesium value greater than 8 milligrams per deciliter, respiratory cardiac arrest. Respond to signs of MAG toxicity. Discontinue MAG if the respiratory rate is below 12 breaths per minute, pulse oximeter rate is decreasing, or DTRs are absent. Additional MAG will make the condition worse. Notify the provider of the woman's condition for additional orders. If the urinary output falls below 30 milliliters per hour, the provider may alter the drug dosage to maintain a therapeutic range. Calcium opposes the effects of magnesium at the neuromuscular junction, and it should be readily available whenever magnesium is administered. MAG toxicity can be reversed by IV administration of 1 gram, 10 milliliter of 10% solution of calcium gluconate over 3 minutes. Evaluation. Collect and compare data with established norms and then determine whether the data are within normal limits. For seizures, interventions are deemed successful if the following occur. Reflexes remain within normal limits, +1 to +3. The woman is free of visual disturbances, headache, and epigastric or right upper quadrant pain. The woman remains free of seizures or free of preventable injury if a seizure occurs. For magnesium toxicity, determine whether respiratory rates remain at least 12 breaths per minute, DTRs are present and not hyperactive, and maternal plasma levels of magnesium do not exceed therapeutic range of 5 to 8 milligrams per deciliter. Hemolysis, elevated liver enzymes, and low platelet syndrome. The syndrome of hemolysis, elevated liver enzymes, and low platelets, HELLP syndrome, is a life-threatening occurrence that complicates approximately 10% of pregnancies. Half of the women affected by HELLP also have severe preeclampsia, although hypertension may be absent. The normotensive woman should be considered to have preeclampsia if she has other signs of reduced organ perfusion. As in preeclampsia, HELLP syndrome may occur during the postpartum period. Hemolysis is believed to occur as a result of the fragmentation and distortion of erythrocytes during passage through small damaged blood vessels. Liver enzyme levels increase when hepatic blood flow is obstructed by fibrin deposits. Hyperbilirubinemia and jaundice may occur as a result of liver impairment. Vasospasm causes vascular damage. Platelets aggregate at sites of damage, resulting in low platelet levels, thrombocytopenia, which increases the risk for bleeding, frequently in the liver. The prominent symptom of HELLP syndrome is pain in the right upper quadrant, the lower right chest, or the mid-epigastric area. The tenderness may result from liver distension. Additional signs and symptoms include nausea, vomiting, and severe edema. Increase in intra-abdominal pressure, including that caused by a seizure, could lead to rupture of a subcapsular hematoma, resulting in internal bleeding and hypovolemic shock. Hepatic rupture can lead to fetal and maternal mortality. Women with HELLP syndrome should be managed in a setting with intensive care facilities. Treatment includes magnesium sulfate to control seizures and hydralazine or labetalol to control blood pressure. Fluid replacement is managed to avoid worsening the woman's reduced intravascular volume without giving her too much, because that could cause pulmonary edema or ascites. Cervical ripening with labor induction may be performed if the gestation is at least 34 weeks. Delivery may be delayed if the gestation is less than 34 weeks and the woman's condition is stable, to allow for steroid administration to stimulate fetal lung maturation. If the woman is near term and has a favorable cervix, induction of labor is preferred to avoid the bleeding and clotting complications that are more likely to occur with cesarean birth. Anesthesia choices are likely to be complicated by laryngeal edema, intubation difficulties, low platelet counts that may reduce safety of epidural block, and coagulation abnormalities that can have an impact on safety of pudendal blocks. Cesarean birth may be necessary if the woman is far from term or has an unfavorable cervix. Chronic hypertension. A diagnosis of chronic hypertension is made if hypertension precedes pregnancy or is identified before 20 weeks of gestation. The diagnosis also can be based on blood pressure that remains elevated beyond postpartum week 12. Chronic hypertension is most often associated with advanced maternal age, obesity, and comorbidities such as diabetes. Heredity, including race, plays a role in the development of chronic hypertension, which is more common in African Americans at any age than in people of other races. Late childbearing and rising obesity rates add to the risks for women. However, hypertension may be secondary to another problem, such as renal disease or an autoimmune disorder. Elevated circulating hormones, prostaglandins, and progesterone cause a decrease in blood pressure during early pregnancy. Therefore, the woman's blood pressure may appear normal when she enters prenatal care. Antihypertensive therapy is reserved for women with consistently elevated systolic pressures above 160 or diastolic pressures above 90 to 100. If she already is taking an antihypertensive drug, she usually continues this drug until her blood pressure becomes low because of vasodilation of pregnancy. Antihypertensive medications should be chosen carefully because they may reduce placental blood flow. Methyldopa, Aldomet, is a drug of choice because of its record of safety and effectiveness in pregnancy. Beta blockers and calcium channel blockers also may be used if methyldopa is not effective, but the record of safety in pregnancy is less well established. ACE inhibitors are not recommended in pregnancy, but may be used in the postpartum period. Hydralazine is a vasodilator reserved for hypertensive crisis. Diuretics are avoided if possible because they may shrink the blood volume, which already may be reduced if preeclampsia exists with the chronic hypertension. In cases of pulmonary edema, diuretics may be necessary. The most common maternal complication is the development of preeclampsia, which occurs in approximately 25% of pregnant women with chronic hypertension. New onset proteinuria or a significant rise in pre-existing proteinuria identifies the development of superimposed preeclampsia. The rise in blood pressure with preeclampsia is likely to be greater in these women. Development of signs and symptoms indicating multi-organ development, headache, epigastric pain, or visual changes, are correlated to abnormal renal, hepatic, or hematologic laboratory values. A dietitian should be consulted about the appropriate diet and weight gain because many of these women are obese and frequently have diabetes. Adequate intake of protein helps counteract the protein lost in urine. A reduced salt intake may be advised, unlike recommendations for the woman with preeclampsia alone. More frequent prenatal visits will be needed. Regular fetal surveillance by BPP and kick counts, see Chapter 9, is recommended to identify fetal compromise, such as poor growth patterns or decreasing amount of amniotic fluid. Incompatibility between maternal and fetal blood. RH incompatibility. Rhesus Rh factor incompatibility during pregnancy is possible only when two specific circumstances coexist. One, the mother is Rh negative, D negative, and two, the fetus is Rh positive. For such a circumstance to occur, the father of the fetus must be Rh positive. Rh incompatibility is a problem that affects the fetus. It causes no harm to the mother. Rh negative blood is an autosomal recessive trait, and a person must inherit the same gene from both parents to be Rh negative. Approximately 15% of the white population in the United States is Rh negative. The incidence is lower in the African American and Asian populations. Pathophysiology. People who are Rh positive have the Rh antigen on their RBCs, whereas people who are Rh negative do not have the antigen. When blood from a person who is Rh positive enters the bloodstream of a person who is Rh negative, the body reacts as it would to any foreign substance. It develops antibodies to destroy the invading antigen. To destroy the Rh antigen, which exists as part of the RBC, the entire RBC must be destroyed. The antibodies do not affect the Rh negative RBCs because they do not have the Rh antigen. Exposure of the Rh negative male or female to Rh positive blood may occur unrelated to a pregnancy, such as during emergency blood transfusion. Destruction of Rh positive cells occurs in the Rh negative person after they have become sensitized, developed antibodies, to the Rh positive antigens. The Rh antigen does not cross an intact placenta. Sensitization of the mother occurs when the Rh positive blood of the fetus enters maternal circulation. Theoretically, fetal and maternal blood do not mix during pregnancy. In reality, small placental accidents occur that allow a drop or two of fetal blood to enter the maternal circulation and initiate the production of antibodies to destroy the Rh positive blood. Sensitization also can occur during a spontaneous or elective abortion or during antepartum procedures such as amniocentesis and chorionic villus sampling. A rapid immune response against Rh positive blood occurs with an extensive fetal maternal hemorrhage in complications such as placenta previa or placental abruption or with an uncomplicated birth. Most exposure of maternal blood to fetal blood occurs during the third stage of labor, when active exchange of fetal and maternal blood may occur from damaged placental vessels. In this case, the woman's first child is not usually affected because antibodies are formed after the birth of the infant. However, since the antibodies remain in the woman's body and cross an intact placenta, subsequent Rh positive fetuses may be affected unless the mother receives Rh immune globulin, ROGAM, to prevent antibody formation after the birth of each Rh positive infant. Fetal and neonatal implications. If antibodies to the Rh factor are present in the pregnant mother's blood, they cross the placenta and destroy Rh positive fetal erythrocytes. The fetus becomes deficient in RBCs, which are needed to transport oxygen to fetal tissue. As fetal RBCs are destroyed, fetal bilirubin levels increase, icterus gravis, which can lead to neurologic disease, kernicterus, staining of brain tissue, leading to bilirubin encephalopathy. This hemolytic process results in rapid production of erythroblasts, immature RBCs, which cannot carry oxygen. The entire syndrome is termed erythroblastosis fetalis. The fetus may become so anemic that generalized fetal edema, hydrops fetalis, results and can end in fetal CHF. Prenatal assessment and management. Women should have a blood test to determine blood type and Rh factor at the initial prenatal visit. Rh negative women should have an indirect Coombs test to determine whether they are sensitized, have developed antibodies as a result of previous exposure to Rh positive blood. If the indirect Coombs test is negative, it is repeated at 28 weeks of gestation to identify whether they have developed subsequent sensitization. Rh immune globulin, ROGAM, is administered to the unsensitized Rh negative woman at 28 weeks of gestation to prevent sensitization, which may occur from small leaks of fetal blood across the placenta. RhoGAM is a commercial preparation of passive antibodies against Rh factor. It effectively prevents the formation of active antibodies against Rh positive erythrocytes if a small amount of fetal Rh positive blood enters the circulation of the Rh negative mother during the remainder of the pregnancy. Administration of RhoGAM is repeated after birth if the woman delivers an Rh positive infant. If the indirect Coombs test result is positive, indicating maternal sensitization in the presence of antibodies, it is repeated at frequent intervals throughout the pregnancy to determine whether the antibody titer is rising. An increase in titer indicates that the process is continuing and that the fetus will be in jeopardy. Ultrasound examination is used to non-invasively evaluate the condition of the fetus. Doppler studies allow evaluation of cardiac function and blood flow in fetal vessels. The systolic blood flow in the fetal middle cerebral artery is a non-invasive way to assess the degree of fetal anemia. An anemic fetus will increase blood flow to the brain in an effort to maintain oxygenation of the CNS. This increased blood flow is detected by Doppler sonography and can be quantified. Blood flow of 1.5 times the median for the fetal gestational age is predictive of moderate to severe fetal anemia. Generalized fetal edema, ascites, and enlarged heart or hydramnios occurs when the fetus is very anemic. Percutaneous umbilical blood sampling, PUBS, or chordocentesis allows invasive sampling of fetal blood from cord vessels to determine the degree of erythrocyte destruction. Because it is invasive, PUBS is reserved for the fetus thought to be significantly affected. Intrauterine transfusion is the direct infusion of O-negative erythrocytes into the umbilical cord by percutaneous umbilical blood transfusion if the fetus is severely affected. The transfused erythrocytes must be compatible with maternal blood to avoid destruction by her antibodies. Whole blood is usually used to replace fetal serum proteins. Erythrocytes also may be transfused into the fetal abdominal cavity, where they are gradually absorbed into the circulation. Postpartum management. If the mother is Rh negative, umbilical cord blood is taken at delivery to determine blood type, Rh factor, and antibody titer, direct Coombs test, of the newborn. Rh negative, unsensitized mothers who give birth to Rh positive infants are given an intramuscular injection of RhoGAM within 72 hours after delivery. If RhoGAM is given to the mother within 72 hours after the birth of an Rh positive infant, she does not form antibodies to the Rh antigen. If the infant is Rh negative, Rh antibody formation does not occur and RhoGAM is not necessary. Families often are concerned about the fetus, and nurses should be sensitive to cues that indicate that the family is anxious, should be able to offer honest reassurance. This is especially important if the woman is sensitized and fetal testing is necessary through pregnancy. During labor, the nurse should carefully label the tube of cord blood obtained for analysis of the newborn's blood type and Rh factor. During the postpartum period, nurses are responsible for follow-up to determine whether RhoGAM is necessary and for administering the injection within the prescribed time. ABO incompatibility. ABO incompatibility occurs when the mother is blood type O and the fetus is blood type A, B, or AB. Types A, B, and AB blood contain an antigen that is not present in type O blood. People with type O blood develop anti-A or anti-B antibodies naturally as a result of exposure to antigens in the foods they eat or to infection by gram-negative bacteria. As a result, some women with blood type O have developed high serum anti-A and anti-B antibody titers before pregnancy. The antibodies may be either IgG or IgM. When the woman becomes pregnant, the IgG antibodies cross the placenta and cause hemolysis of fetal RBCs. Although the first fetus can be affected, ABO incompatibility is less severe than RH incompatibility, as the primary antibodies of the ABO system are IgM, which do not readily cross the placenta. No specific prenatal care is needed. However, the nurse should be aware of the possibility of ABO incompatibility. During the delivery, cord blood is taken to determine the blood type of the newborn and the antibody titer. Direct Coombs test. The newborn is carefully screened for jaundice, which indicates hyperbilirubinemia. Concurrent conditions. Pregnancy affects the care of the woman with a medical condition in two ways. First, pregnancy may alter the course of the disease. Second, the disease or its treatment may have unwanted effects on the pregnancy. Antepartum care should be adapted to include increased surveillance of the mother and the fetus. Diabetes. Etiology and pathophysiology. Diabetes mellitus is a complex disorder of carbohydrate metabolism caused primarily by a partial or complete lack of insulin secretion by the beta cells of the pancreas. Some cells, such as those in skeletal and cardiac muscles and adipose tissue, rely on insulin to carry glucose across the cell membranes. Without insulin, glucose accumulates in blood, resulting in hyperglycemia. The body attempts to dilute the glucose load by any means possible. The first strategy is to increase thirst, polydipsia, a classic symptom of diabetes mellitus. Next, fluid from the intracellular spaces is drawn into the vascular bed, resulting in dehydration at the cellular level, but fluid volume excess in the vascular compartment. The kidneys attempt to excrete large volumes of this fluid and the heavy solute load of glucose, osmotic diuresis. This excretion produces the second hallmark of diabetes, polyuria with glycosuria, glucose in the urine. Without glucose, the cells starve, so weight loss occurs, even though the person ingests large amounts of food, polyphagia. Because the body cannot metabolize glucose, it begins to metabolize protein and fat to meet energy needs. Metabolism of protein produces a negative nitrogen balance, and the metabolism of fat results in the buildup of ketone bodies, e.g. acetone, acetoacetic acid, or beta-hydroxybutyric acid, or ketosis, accumulation of acids in the body. If the disease is not well controlled, serious complications may occur. Hypoglycemia or hyperglycemia can result if the amount of insulin does not match the diet. Fluctuating periods of hyperglycemia and hypoglycemia damage small blood vessels throughout the body. This damage can cause serious impairment, especially in the kidneys, eyes, and heart. Effect of pregnancy on fuel metabolism. To understand the relationship between diabetes and pregnancy, an understanding of the way pregnancy and diabetes alter the metabolism of food is necessary. Early pregnancy. Metabolic changes can be divided into those that occur early in pregnancy from 1 to 20 weeks of gestation and those that occur late in pregnancy from 20 to 40 weeks of gestation. In early pregnancy, maternal metabolic rates and energy needs change little. During this time, however, insulin releases in response to serum glucose levels accelerates. As a result, significant hypoglycemia may occur as more glucose is transported into the cells. The nausea, vomiting, and anorexia that often arise during the first weeks of pregnancy may increase the incidence of hypoglycemia. In an uncomplicated pregnancy, the availability of glucose and insulin, a lipogenic substance, favors the development and storage of fat during the first half of pregnancy. Accumulation of fat prepares the mother for the rise in energy used by the growing fetus during the second half of pregnancy. Late pregnancy. During the second half of pregnancy, levels of placental hormones rise sharply. These hormones, particularly estrogen, progesterone, and human placental lactogen, HPL, create resistance to insulin in maternal cells. This resistance allows an abundant supply of glucose to be available in the mother's blood for transport to the fetus. The hormones have a diabetogenic effect in that they may leave the woman with insufficient insulin and episodes of hyperglycemia. For most women, insulin resistance is not a problem. The pancreas responds by simply increasing the production of insulin. If the pancreas is unable to respond adequately, the woman will have periods of hyperglycemia. Birth. Maintenance of normal maternal glucose levels is essential during labor and birth to reduce neonatal hypoglycemia. Women with diabetes usually maintain their glucose testing and continue administration of doses of insulin the day before scheduled induction or cesarean birth. Women with an insulin pump continue using their pump through the night. After admission with nothing by mouth, (NPO), after the prescribed time, their glucose level is checked and continuous infusion of insulin and glucose is started based on hourly glucose levels. Postpartum period. The need for additional insulin falls during the postpartum period. Breastfeeding is encouraged not only for the newborn's benefit, but also because the added calorie used for lactation by the mother helps lower the amount of insulin needed in women with diabetes. The women with gestational diabetes usually need no insulin after birth, but the greater risk for later development of type 2 diabetes should be emphasized with teaching before discharge. Classification. Diabetes that exists before pregnancy is classified as type 1 insulin deficient or type 2 insulin resistant, with a relative deficiency of insulin to metabolize carbohydrate. A third type is one in which any degree of glucose intolerance has its onset or first recognition during pregnancy. The term gestational diabetes refers to the onset of glucose intolerance during pregnancy. An additional classification of diabetes is sometimes used for descriptive purposes. The White classification describes the age at onset of diabetes, its duration based on the woman's current age, and vascular complications, such as retinopathy, that are present. GDM descriptions in White's classification include A1, diet controlled, and A2, diet and insulin controlled. Another classification for diabetes during pregnancy lists complications that may be found with type 1 or type 2 diabetes, retinopathy, nephropathy, coronary artery disease, and whether GDM is controlled by diet alone or also requires insulin to supplement diet control. Incidence. Diabetes is a common medical condition that often affects pregnancy. Approximately 90 to 95% of diagnoses in the total population are of type 2, whereas type 1 accounts for about 5% of those diagnosed. The pregnant woman may have pre-existing diabetes, type 1 or type 2, or she may develop GDM during the course of pregnancy. The pregnant woman may have had undiagnosed diabetes, type 2, that is discovered during pregnancy screening for GDM and remains during the postpartum period. Although the true incidence of gestational diabetes is unknown, one U.S. study found a prevalence rate of 9.2%, with a range of 16.3 to 6.8% among different ethnic groups. The highest rates were found in Asian American or Pacific Islanders and Hispanics or Latinos, with the lowest rates in non-Hispanic whites. I really feel like the Asians just cannot catch a break with this pregnancy stuff. About half of women with GDM will develop type 2 diabetes later in life. Pre-existing diabetes. The course of pregnancy for women with diabetes has improved greatly as a result of treatments and more effective methods of fetal surveillance. However, the incidence of complications affecting the mother and fetus remains higher than that experienced by women who do not have diabetes. Maternal effects. Diabetes can adversely affect a pregnant woman and her developing baby in several ways. During the first trimester, when major fetal organs are developing, the effects of the abnormal metabolic environment, such as in hypoglycemia, hyperglycemia, and ketosis, may lead to increased incidence of spontaneous abortion or major fetal malformations. Hypertension, especially preeclampsia, is more likely to develop if the woman has pre-existing diabetes. The development of ketoacidosis is a threat to women with type 1 diabetes and is most often precipitated by infection or missed insulin doses. In addition, ketoacidosis may develop in these women at lower thresholds of hyperglycemia than those seen in non-pregnant individuals. Untreated ketoacidosis can progress to fetal and maternal death. UTIs are more common, possibly because of glucose in the urine, which provides a nutrient-rich medium for bacterial growth. Other effects include hydramnios, which may result from fetal hyperglycemia and consequent fetal diuresis and premature rupture of membranes, which may be caused by overdistension of the uterus by hydramnios or a large fetus. rise during labor and childbirth if the fetus has macrosomia, weighs more than 8.8 pounds, 4,000 grams, may include a difficult labor, shoulder dystocia, delayed or difficult birth of fetal shoulders after the head is born, and consequent injury to the birth canal or the infant. Large fetal size also increases the likelihood of a cesarean birth and the risk for postpartum hemorrhage. Table 10.6. Fetal effects. Fetal and neonatal effects of pre-existing diabetes depend on the timing and severity of maternal hyperglycemia and the degree of vascular impairment that has occurred. Congenital malformation. Fewer malformations occur if the woman maintains a normal blood glucose level before conception and throughout pregnancy. The risk for a major congenital malformation is 2 to 6 times higher than for the general population of pregnant women if maternal hyperglycemia is not controlled during the first trimester. The most common major congenital malformations associated with pre-existing diabetes are neural tube defects, caudal regression syndrome, failure of sacrum, lumbar spine, and lower extremities to develop, and cardiac defects. Variation in fetal size. Fetal growth is related to maternal vascular integrity. In women without vascular impairment, glucose and oxygen are easily transported to the fetus. If the mother is hyperglycemic, so is the fetus. Although maternal insulin does not cross the placental barrier, the fetus produces insulin by the 10th week of gestation. Fetal macrosomia results when elevated levels of blood glucose stimulate excessive production of fetal insulin, which acts as a powerful growth hormone. This is a major neonatal effect with consequent increase in the rate of cesarean birth or birth injury from shoulder dystocia. Conversely, if vascular impairment is present in the mother, placental perfusion may be decreased. Vascular impairment may be caused by complications of the diabetes such as vasoconstriction, which occurs in preeclampsia or a result of the disease process of diabetes. Impaired placental perfusion decreases supplies of glucose and oxygen delivered to the fetus. As a result, the infant is likely to be small for gestational age, SGA. This condition is called intrauterine growth restriction, IUGR. Amniotic fluid may be reduced, hydramnios, as the fetus conserves oxygen for the heart and brain rather than providing normal circulation to the kidneys. Neonatal effects. The four major neonatal complications of pre-existing diabetes are hypoglycemia, hypocalcemia, hyperbilirubinemia, and respiratory distress syndrome. Maintaining normal maternal levels of glucose reduces the incidence and severity of neonatal complications. Hypoglycemia. The neonate is at higher risk for hypoglycemia because fetal insulin production would have been accelerated during pregnancy to metabolize the excessive glucose received from the mother. The constant stimulation of hyperglycemia leads to hyperplasia and hypertrophy of the islets of Langerhans in the fetal pancreas. When the maternal glucose supply is abruptly withdrawn at birth, the level of neonatal insulin exceeds the available glucose, and hypoglycemia develops rapidly. Hypocalcemia. Hypocalcemia is defined as a total serum calcium level of less than 7 milligrams per deciliter in a preterm infant or less than 8 milligrams per deciliter in a term infant. It is likely due to relative hyperparathyroidism seen in many diabetic mothers. Other possible causes include changes in the magnesium-calcium balance, asphyxia, or preterm birth. Hyperbilirubinemia. The fetus experiencing recurrent hypoxia compensates by production of additional erythrocytes, polycythemia, to carry oxygen supplied by the mother. After birth, the excess erythrocytes are broken down, which releases large amounts of bilirubin into the neonate's circulation. Prematurity, more likely in the infant of a woman with poor glycemic control, further reduces the infant's ability to metabolize and excrete excess bilirubin. Respiratory distress syndrome. Fetal hyperinsulinemia retards cortisol production, which is necessary for the synthesis of surfactant needed to help the newborn's alveoli open after birth, thereby increasing the risk for respiratory distress syndrome. Reduced lung field clearance and delayed thinning of lung connective tissue also may be a factor. Respiratory distress syndrome is more likely to occur if the mother's glycemic control is poor, because wide fluctuations in her insulin and glucose levels have slowed lung maturation. Tests of fetal lung maturity will be done before elective delivery of the fetus by induction or scheduled cesarean birth if questions about maturity exist. Complications in a mother and her fetus, and then her newborn, can be reduced if the mother maintains control and stable blood glucose levels. The objective of the team providing treatment is to devise a plan that allows a woman to maintain a level as close to normal as possible. Maternal assessment. Preconception care is ideal in a woman with pre-existing diabetes. If the woman can have her body in the best condition before conception, including diabetes management, pregnancy is likely to have fewer or less severe complications than if she started care after conception. When the woman with preconception care or pre-existing diabetes initiates care, a thorough evaluation of her health status should be completed. This evaluation includes history, physical examination, and laboratory tests. History. A detailed history should include the onset and management of the diabetic condition. How long has she had the disease? How does she maintain a normal blood glucose level? Is she familiar with ways to monitor blood glucose level and administer insulin? The degree of glycemic control before pregnancy is of particular interest. Effective management depends on her adherence to a plan of care. Therefore, her knowledge of how diabetes affects pregnancy and how pregnancy affects diabetes should be determined. The support person's knowledge also should be assessed, and specific learning needs should be identified. In addition, the woman's emotional status should be assessed to determine how she is coping with pregnancy superimposed on pre-existing diabetes. All women with diabetes should be seen by a qualified diabetes educator for an individualized assessment to ensure these women can monitor their blood glucose level accurately. Accurate readings depend on performing the test correctly and at the times recommended by the healthcare team. In addition to home monitoring of blood glucose level, the nurse should observe the woman's skill in mixing and self-administering insulin, using a sliding scale for added insulin, or using an insulin pump if the drug will be given that way. Most pregnant women who need medication to reduce glucose levels take insulin via injection rather than as an oral agent, even if the oral agent had been effective in the woman with type 2 diabetes. The current ACOG recommendation is limited on the individualized use of oral agents during pregnancy. Physical examination. In addition to routine prenatal examination, specific efforts should be made to assess effects of diabetes. Baseline electrocardiogram should be obtained to determine cardiovascular status. Evaluation for retinopathy should be performed, with referral to an ophthalmologist if necessary. The woman's weight and blood pressure should be monitored because of the increased risk for hypertension, including preeclampsia. Fundal height should be measured, noting any abnormal increase in size that may indicate macrosomia or hydramnios, which may occur as a result of diuresis by the hyperglycemic fetus. Fundal height less than expected for the gestation may indicate fetal growth restriction or intrauterine death secondary to poor placental perfusion. Laboratory tests. In addition to routine prenatal laboratory examinations, renal function should be assessed with a 24-hour urine collection for total protein excretion and creatinine clearance. A random urine sample should be checked at each prenatal visit for possible UTIs, which are common in women with diabetes. Urine also should be checked by using a dipstick for the presence of glucose, ketones, and protein. Thyroid function tests should be performed in the woman with the pre-existing diabetes because of her risk for coexisting thyroid disease. Glycemic control should be evaluated on the basis of the level of glycosated hemoglobin or hemoglobin A1C. The glycosated hemoglobin assay is an accurate measurement of the average glucose concentrations during the preceding 2 to 3 months. Unlike tests that reflect the amount of glucose in the plasma at the moment, the HbA1c measurement is not affected by recent intake or restriction of food. Fetal surveillance. Because of the increased risk for congenital anomalies or fetal death, surveillance should begin early for women with pre-existing diabetes. Testing for anomalies includes multiple marker screening to identify possible neural tube or other open defects, and for possible chromosome abnormalities. Testing also includes performing ultrasonography at 18 to 20 weeks of gestation and fetal echocardiography at 20 to 22 weeks of gestation to determine the integrity of the fetal body and cardiac structure. During the third trimester, the goal of fetal surveillance is to identify markers that suggest a worsening intrauterine environment with an increased risk for fetal death. Surveillance may include maternal assessment of fetal movement, kick counts, BPPs, and NSTs, and contraction stress tests. Serial sonograms are used to document fetal growth rates in an effort to identify fetuses at risk for macrosomia and shoulder dystocia. Doppler velocimetry of the umbilical artery may be used to assess vascular complications and poor fetal growth. Therapeutic management. The goals of therapeutic management for a pregnant woman with diabetes are to 1. Maintain normal blood glucose levels, 2. Facilitate the birth of a healthy baby, and 3. Avoid accelerated impairment of blood vessels and other major organs. To achieve this outcome, an intensive team approach to care is required. Members of the team often include an endocrinologist or diabetologist who assists in regulation of maternal blood glucose level, an obstetrician or a maternal fetal medicine specialist, perinatologist, who monitors the mother and fetus and determines the optimal time for birth, a registered dietitian or registered dietary technician, RDT, who provides a balanced meal plan, and a diabetes educator, often a specialized nurse, who provides ongoing education and support as the therapy changes throughout pregnancy. The team is completed by a neonatologist who will care for the newborn, the family physician, and the pediatrician, who will provide ongoing care for the infant and the mother. Preconception care. Ideally, care should begin before conception. If diabetes exists before pregnancy, both prospective parents should participate in care sessions to learn more about the following measures that need to be taken by the healthcare team. Establishing the optimal time to undertake pregnancy based on maintenance of normal maternal blood glucose levels to reduce the risk for major fetal malformations. Identifying whether diabetes complications exist in other organ systems. Determining the degree of glycemic control based on client records or laboratory studies. Instructing a woman about how to use a glucometer for blood glucose level measurement and having the woman demonstrate correct technique. The woman take a daily prenatal vitamin with folic acid. A higher dose of folic acid is recommended for the woman who had a previous child with an NTD, Chapter 8. Diet. Diet recommendations are individualized during pregnancy in a woman with diabetes. The average recommended caloric intake for the pregnant woman with diabetes who is of normal weight is 30 to 35 kilocalories per kilogram of body weight per day. Approximately 40 to 50% of the calories should be from high fiber complex carbs, 20% from protein, and up to 30 to 40% from fat. Caloric intake should be distributed among 3 meals and 2 or more snacks. Bedtime snacks should include a complex carbohydrate and protein. Women who are overweight or underweight usually have lower or higher caloric goals. Self-monitoring of blood glucose level. The best frequency for self-monitoring of blood glucose level, SMBG, level of capillary blood, has not yet been established. One common testing regimen requires obtaining fasting and 2-hour postprandial levels. Another includes testing 6 times per day a fasting capillary glucose level, 1 to 2 hours after breakfast, 4 and after lunch, before dinner, and at bedtime. Normal fasting and postprandial glucose levels have been associated with better outcomes, including a lower risk for macrosomia, neonatal hypoglycemia, and labor dystocia that results in a cesarean birth. So preprandial just means before you eat. Preprandial glucose levels may be needed for smoother control if the glucose level is difficult to control. The target capillary blood glucose levels are as follows: fasting 95, pre-meal 100 or less, 1 hour postprandial 140, and 2 hour postprandial 120. In addition to regular monitoring, the woman also should perform a glucose test whenever she experiences symptoms of hypoglycemia. The woman should record all test results on a log sheet or cell phone app for review by the healthcare provider at each visit. Insulin therapy. The need to maintain rigorous control of maternal metabolism during pregnancy requires more frequent doses of insulin than usual. Most treatment regimens rely on 3 daily injections with a combination of short-acting regular insulin and intermediate-acting neutral protamine Hagedorn NPH insulin given before breakfast, regular insulin before dinner, and NPH insulin at bedtime. Lispro and Aspart, Humalog and Novolog respectively, insulins act rapidly and should be injected just before a meal. Rapid-acting insulins have been shown to control postprandial hyperglycemia with less between-meal hypoglycemia. Because placental hormones cause insulin needs to change throughout pregnancy, insulin coverage will need to be adjusted as pregnancy progresses. First trimester. Insulin needs generally decline during the first trimester because the secretion of placental hormones antagonistic to insulin remains low. The woman also may experience nausea, vomiting, and anorexia, which result in decreased intake of food. Therefore, the woman requires less insulin. In addition, the fetus receives its share of glucose, which reduces maternal plasma glucose levels and decreases the need for maternal insulin. Second and third trimesters. Insulin needs increase markedly during the second and third trimesters when placental hormones, which initiate maternal resistance to the effects of insulin, reach their peak. In addition, the nausea of early pregnancy usually resolves, and the diet includes additional calories per day to meet the increased metabolic demands of pregnancy. During labor, maintenance of tight maternal glucose control during birth is desirable to reduce neonatal hypoglycemia. Continuous infusion of a regular insulin solution combined with a separate IV solution containing glucose such as 5% dextrose in lactated Ringer's solution allows titration to maintain blood glucose levels between 80 and 110 or according to facility policy. The insulin solution is raised, lowered, or discontinued to maintain euglycemia based on hourly capillary blood glucose levels. Postpartum period. Insulin needs should decline rapidly after the delivery of the placenta and abrupt cessation of placental hormones. However, blood glucose levels should be monitored at least 4 times daily so that the insulin dose can be adjusted to meet individual needs. Women with type 1 diabetes usually return to their pre-pregnancy dosages. Women with type 2 diabetes are monitored as ordered, and insulin is ordered only if needed. Timing of delivery. If possible, the pregnancy is allowed to progress to 39 weeks or later to allow the fetal lungs to mature, reducing the risk for neonatal respiratory distress syndrome. With evidence of fetal compromise, such as a low BPP or reduced amniotic fluid, delivery may be required. Delivery before completion of 38 weeks is needed for non-emergency reasons. Amniocentesis to determine fetal lung maturity is often performed because lung maturation may be slower than in non-diabetic pregnancies. Cesarean birth may be considered to avoid traumatic birth injuries if the estimated fetal weight is more than 4,500 grams. Gestational diabetes. Any degree of carbohydrate intolerance first diagnosed during pregnancy is classified as GDM. However, as the incidence of obesity and type 2 diabetes has increased, the number of women of childbearing age with undiagnosed pre-existing diabetes also has increased. Therefore, the ADA recommends a refinement of the definition to diabetes diagnosed in the second or third trimester of pregnancy that was not clearly overt diabetes before gestation. Women with risk factors should be tested for undiagnosed diabetes at their first prenatal visit. Diabetes identified during the first trimester should be classified as pre-existing pregestational diabetes rather than gestational diabetes. GDM is an added risk factor that a woman will develop type 2 diabetes later in life. Factors such as obesity, inactivity, abnormal cholesterol levels, vascular disease, or family members with type 2 diabetes further increase a woman's risk for developing type 2 diabetes. Risk factors. Diagnosis of GDM begins with history taken to identify the woman at risk. Factors known to increase the risk include the following: overweight, body mass index, BMI over or equal to 25 to 25.9, obesity, BMI greater than or equal to 30 or morbidly obese, BMI 40 or higher. Maternal age older than 25 years. Previous birth outcomes often associated with GDM, neonatal macrosomia, maternal hypertension, infant with unexplained congenital anomalies, previous fetal death, gestational diabetes in previous pregnancy, history of abnormal glucose tolerance, history of diabetes in a close first-degree relative, members of a high-risk ethnic group, African American, Hispanic or Latino, American Indian, Asian American, or Pacific Islanders, history of prediabetes, elevated blood glucose that does not meet the criteria for diabetes, history of polycystic ovary syndrome, PCOS. Women with any of these factors should be screened for type 2 or gestational diabetes at the first prenatal visit. Identifying gestational diabetes. Screening. Women without any risk factors for gestational diabetes may be screened by history alone. Blood glucose testing is not routinely required. For women with one or more risk factors, a two-step approach is the current recommendation for screening for GDM by the NIH and ACOG. Glucose challenge test. A GCT is administered between 24 and 28 weeks of gestation. Fasting is not necessary for a GCT, and the woman is not required to follow any pre-test dietary instructions. The woman should ingest 50 grams of oral glucose solution. A blood sample is taken 1 hour later. If the blood glucose concentration is 140 or greater, a 3-hour oral glucose tolerance test, OGTT, is recommended. Some practitioners use a lower cutoff of 130 or 135 to identify more women at risk. Oral glucose tolerance test. The 3-hour OGTT is the gold standard for diagnosing diabetes, but it is a more complex test. The woman must fast from midnight on the day of the test. After a fasting plasma glucose level is determined, the woman should ingest 100 grams of oral glucose solution. Plasma glucose levels are then determined at 1, 2, and 3 hours. A diagnosis of GDM is made if 2 or more of the values meet or exceed the threshold. Fasting 95, 1 hour 180, 2 hours 155, 3 hours 140. Based on patient population, available resources, regional practice, and institutional policy, some providers may use thresholds of 105 for fasting, 190 for 1 hour, 165 for 2 hours, and 145 for 3 hours.